in Germany. And I'm specialized on surgery of sarcomas. And today I'd like to talk to you about the retroperitoneal sarcomas, how we do the treatment for it, and whether the compartmental resection of retroperitoneal sarcoma is still justified. At the beginning, I'd like to declare that I have no conflicts with neither financial nor non-financial conflicts of interest with this lecture. And as I've told you, we'll talk about the retroperitoneal sarcoma and results of sarcoma boards and the treatment of sarcomas in Germany, about the biopsy taking and the prognostic parameters affecting the outcome of sarcomas, and about the surgical therapy and the quality of surgical resection in primary and in recurrent retroperitoneal sarcoma. At the beginning, sarcomas, as you all surely know, are very rare malignancies. They constitute of less than 1% of all adult malignancies, with about 4 to 5 new cases every 100,000 residents per year in industrialized nations. They are very heterogeneous, or they have very heterogeneous histology, and have more than 80 different defined histological sub-entities. They are very interesting in general because they arise everywhere in the body, in every tissue, most commonly in the lower limbs, then the upper limbs, then torso and retroperitoneum, uterus, head and neck, and of course in the central nervous system. Because they're so rare tumors, they have commonly been treated as one group, which is, of course, nowadays unacceptable. Of course, you all know these CT scans of retroperitoneal sarcomas sometimes is affecting blood vessels, the big major vessels of retroperitoneum, sometimes not. When we see such a patient in Germany, before we decide what to do, we usually discuss these patients in the interdisciplinary tumor boards, because there are many different arms of treatment, radiotherapy, surgery, chemotherapy, and regional hyperthermia. But we did a study in Germany the past few years we registered all new cases that arose in Germany between 2017 and 2020. There were more than 1,300 patients, new sarcoma cases. And we found out that almost 90% were discussed interdisciplinary before.
Ich bin keine Person. Ich habe keine Religion.
Throughout the disease, about half of the patients were discussed prior to beginning a therapy, about 80% after beginning a therapy, and 85% when metastasized. And actually, that only 56% are discussed prior to therapy is unacceptable. Of course, we all know the OOPS procedures and incidentalomas of sarcomas when you resect a lipoma, and surprisingly at the end it was a sarcoma, but of course not even half of the new cases are incidentalomas. So this is something that needs to be worked on to get better results for it. And usually the first step after discussing these patients is taking a biopsy. But why do we do it actually? We know the most common histological subtypes, but we usually do it because of the grading of the sarcoma, which has major effect on the further therapy, whether we start with a neoadjuvant chemotherapy, whether with or without regional hyperthermia, or radiotherapy, or should we perform surgery at the first step? The most common histological subtypes in the retroperitoneum are the liposarcomas. The dedifferentiated constitute about 1/3 of all retroperitoneal sarcomas, the well-differentiated about 1/4. The leiomyosarcomas make about 20%, the solitary fibrous tumor 5%, and the MP-NST is about 3%, and all the rest of the sub-entities that can arise make altogether a group of 14%. At the beginning, I'd like to talk to you about taking the biopsy. Of course, you all know the fine needle aspiration biopsy is obsolete in solid tumors. So in Germany, we have the standard of if it's a closed incision biopsy, it's done by a core needle biopsy, whether CT or ultrasound guided. Here, the CT guided are always performed by the radiologist, the ultrasound usually by the surgeon himself. And if the radiologist is the one to perform the biopsy, you need to discuss with him and define with him the approach and the localization of taking the biopsy, because this approaching site should be resected later on with the tumor. And of course, you must be aware of taking no necrotic material, because it will result in no pathological result that can help in defining the treatment. And the guidelines, the new ones, defined at least 3 specimens to make possible for the pathologist to make all the analysis he needs to perform to define which type, which sub-entity the sarcoma has and which grading it has. The open biopsy, of course, you know, there's the excisional biopsy. We only perform it when a complete resection of the tumor is possible, and only in tumors with less than 5 centimeters in diameter. And the incisional biopsy is done when the tumor will not be resected at the whole at once because of critical adjacent structures like big or major blood vessels or nerves. And of course, this site of taking the biopsy will be resected later on also with the tumor. And the specimen should be about 1 cubical centimeter with such or with so much material, the pathologist will have no excuses of giving you all the answers you need. Coming to the prognosis of retroperitoneal sarcoma, the 5 years survival rate is about 66%. The local recurrence rate is about 1/4 of the patients, and distal metastases occur in about 1/5 of the patient within the first 5 years. Many groups tried to analyze whether the histology, the sub-entity, has any influence on the outcome of these patients. So the first group is an Italian. They made a study of 2 centers of about 380 patients, and they saw the multivariate analysis, as you can see in the table, the size of the tumor, considering the overall survival, the size of the tumor had a major effect. The surgical resection had no effect on the overall survival. The grading of the tumor was highly significant. Regarding the local recurrence, the size of the tumor and the grading also had a major effect, and the quality of surgical resection, which means the complete resection or incomplete resection. The incomplete resection made almost a 6-fold more relapse rates, local relapse rates than the complete resection. Oh, I'm sorry. And with distant metastasis, there were also the same factors, the grading of the tumor and the histological subtype are the main ones that influence the outcome. So if you can see here, for example, the leiomyosarcoma has worse overall survival, overall rates of distant metastasis than, for example, the solitary fibrous tumor. So we can say that there are many factors that are prognostic for these patients and influence the outcome. The first one is the patient's factors that he brings with. It's his general condition, of course, and his age. The older the patient, the worse is the outcome. And then the tumor-associated factors that are the tumor size and the grade of histological differentiation and the histologic subtypes. And the only factor that we can influence really is the quality of the surgical resection. So I start talking about histological subtype. As you can see here in the Kaplan marker for the overall survival, for example, you can see that the well-differentiated liposarcoma and the solitary fibrous tumor, they have much better overall survival compared to all other histological subtypes. Regarding the local relapse, as you can see, the solitary fibrous tumor and the leiomyosarcoma make much less local relapse than all other types. And with distant metastasis, as you can see, also here, the dedifferentiated G2 liposarcoma, the solitary fibrous and the malignant peripheral nervous sheath tumor also make much less distant metastasis than the other ones. So now the numbers in a table. As you can see, about 90% of the well-differentiated liposarcoma make it up to 5 years. Also, the solitary fibrous tumor, 85% of the affected patients survive the first 5 years. Very interesting is that the well-differentiated liposarcomas in this group, in this cohort of patients, showed no distant metastasis at all. The G2 dedifferentiated liposarcoma made about 10% distant metastasis. And then the leiomyosarcoma and the solitary fibrous tumor make almost no local recurrence compared to others. So these were the factors, the histologic subtype that affect the outcome of the patients. And now we go to the quality of the surgical resection that we can influence. Before we start with it, I'd like to repeat with you the different sorts of resection. The intralesional resection is, of course, the one that we never actually do, except in palliative cases, or when debulking, or when the big size of the tumor makes local symptoms like ileus or bowel obstruction. So if it's a palliative case, you can reduce the size of this tumor to just make a better quality of life for the rest of the days that this patient has. The marginal resection is the complete resection of the tumor without safety margin of healthy tissue around it. The wide resection is, of course, complete resection of the tumor with a wide safety margin of at least 2 to 3 centimeters, completely healthy tissue in all dimensions. And the compartmental resection is the one that has been the gold standard for sarcomas, whether in the extremities. It was defined at the beginning only for sarcomas of the extremities, but was also taken for the retroperitoneal sarcomas. So before performing surgery, of course, you make your thoughts and you plan your surgery well, and you have to define how to perform the surgery. So, for example, in this case, that was a 68 years old female who came to us with this CT scan with this retroperitoneal mass behind inferior vena cava. And as you can see in the middle picture, it was also infiltrating the left renal vein. And in the right one, the sagittal picture, as you can see, it was infiltrating the dorsal wall of the inferior vena cava. So here you must resect the inferior vena cava, of course. In this case, that was a 73-year-old man. That was a local recurrence. As we were talking about the quality of resection, as you can see here, out of these CT scans, the primary resection was not, it's hard to say, but we must say it was not enough. The quality was poor, actually, because as we can see, the whole body of fat of the retroperitoneum is present. You see the kidney, the spleen, the iliopsoas muscle, nothing has changed to the normal anatomy. So actually we can say that prior surgery was only an extirpation of the tumor mass. So no wonder that it relapsed exactly 1 year after the surgery. So in this case, we also, of course, performed a complete compartmental resection, resecting the diaphragm and the left cross of the diaphragm, the iliopsoas muscle, the left kidney, the spleen. We could spare the pancreas because, as we can see in the actual pictures, there were many centimeters distance between the pancreas and the mass. So we could spare it because it makes, of course, a big difference whether resecting a pancreas or not. Okay, is it really justified to resect so many organs even if the mass is not really adjacent to them? That was the case in an American group. They analyzed 118 patients with primary retroperitoneal sarcomas, where they resected the whole of 302 organs. Mostly there were kidneys, of course, colon and adrenal glands. They asked the surgeon why they performed this resection, whether it was assumed invasion, whether the blood supply of the different organs was affected, whether the organs were encapsulated, or whether there was adjacency of the tumor to, with the organs resected. So in about 17%, the surgeon assumed invasion. Histologically, it was confirmed in only 65% of these cases. In 13%, they resected the organs because of the affected blood vessels. An organ encapsulation was in 14%. And interestingly, of these encapsulated organs, only about 1/5 of them was really invaded by the tumor, which no one expects. When a mass encapsulates an organ, you always expect that it's been invaded, but it was only confirmed in 20% or 19% of the cases. The surgeons also resected neighboring organs because of adjacency, without the assumption of these organs being invaded by the tumor. And surprisingly, although they saw these organs were just adjacent to the mass, they were not adherent to it, there was an infiltration or invasion of these organs in about 1/4 of the patients, in 26%. These data show us that we cannot only rely on our macroscopic assumption intraoperatively. And interestingly, they found out that in 50% of the cases, the well-differentiated liposarcoma, the surgeon assumption was correct. In about 80%, it was correct, and dedifferentiated liposarcoma and leiomyosarcoma in about 100%. So how we do it? We always we perform the compartmental resection of the retroperitoneum, always via midline incision. And in this case, that's the patient with the left recurrence that we had seen the pictures from. That's this patient exactly. So we start always with the midline structures because they are always the most important ones. As we can see here, that's the left renal vein, the ureter, and the caudal part. The aorta is here behind the bowel. Behind this retractor was the pancreas. As I told you, we had decided to spare the pancreas because of the many centimeters distance between it and the mass. And after resecting the tumor from the midline and preparing it from the aorta and from all the midline structures, you're almost done with the surgery because the rest is actually much easier. Just preparing the fatty body from the whole retroperitoneum, from the wall of the retroperitoneum and the ribs. And of course, you must not forget the diaphragm cranially. And if everything was done correctly, this is how the specimen looks like at the end. So we resect the whole retroperitoneum. It comes as a whole. We don't see a tumor as we follow the technique don't touch and don't see in performing sarcoma surgery. We don't want to see the tumor before resecting the whole compartment outside of the body. And as you can see here, the garrota fascia is still on the retroperitoneum only in the place where the pancreas lies. We decided to keep the garrota fascia on the pancreas to minimize the risk of developing a pancreatitis postoperatively. The same way, the same approach is used for the right-sided compartmental resections. The only difference is when you have major blood vessels involved, as in the pictures we had seen at the beginning, there was an invasion of the inferior vena cava. So in this case, we perform it from the lateral, from the cranial and dorsal parts, and end up with the last step at the midline or the medial structures to lower the time of clamping the big vessels. And as you can see here, we resected much amount of the diaphragm. You can see that there was no fat in the body left, and as the last step of the surgery, we resect, of course, after clamping the inferior vena cava, resected, and here we used the ring augmented Gore-Tex prosthesis with reinsertion of the left renal vein. This patient, this surgery performed it 5 years ago. Until now, the patient has excellent data with no local relapse nor distant metastasis, and is actually in a very good condition until now. But we always, or we commonly have the discussion in the interdisciplinary tumor boards with the oncologists, radiotherapists, and everyone else, whether this radical resection is justified or not, and how about complication rates postoperatively, and does the age of the patient really affect it or not? So here are the data from more than 1,000 patients with a median follow-up of about 5 years, exactly 58 months. And as you can see from the numbers that, the highest complication rates are for postoperative bleeding or hematoma, and anastomotic leak or fistula. They're less than 3%. And all other complications are less than 2%. So that's not really more than the complication rates you expect after major surgeries. So according to these numbers, yes, it's justified. But how about the effect of these postoperative complications on the oncological outcome of these patients? As you can see here in the multivariate and univariate models, the resected organs, according to the organ weighted score, the higher the organ weighted score, the worse the outcome. That's of course. And having a radiotherapy or a chemotherapy did not affect the outcome. And interestingly, of course, the transfusion, the amount of blood units required intraoperatively had effect on the outcome. And I believe this is logical, because having a major bleeding means having intraoperative complication. And do these data affect the oncological outcome? And these are the 5 and 10-year survival rates and rates of local recurrence and distant metastasis of this cohort of patients. And as you can see, there's for 5 years survival, it's the same numbers, almost the same ones as the overall survival rates for retroperitoneal sarcomas. About 65 to 70% for overall survival, about 1/4 develop a local recurrence, and 1/5 develop a distant metastasis. So postoperative complications have no influence. Actually, on overall survival, or let's just say on the oncological outcome of the patients. We expect no higher morbidity nor mortality after extended retroperitoneal resections in primary retroperitoneal sarcomas. But how about the local relapse rates? Out of these 1,000 patients, about 219 developed a local recurrence, with a median of 33 months when they developed the recurrence. The follow-up was about 37 months, and after primary section, it was 76 months. And as you can see, the smaller the time period from primary surgery until the development of local recurrence, the worse of the overall survival. The worst degrading also constitutes with just significant worse overall outcome. Whether a local recurrence is being resected or not has also a major effect on the outcome, as non-resected local recurrence has almost 5 folds more or worse overall outcome than the resected ones. Chemotherapy and radiotherapy did not affect the outcome. Here's the diagram. As you can see, it shows it clearly that the resected organs have much better outcome or probability to survive than non-resected. So patients with local recurrence have much worse 5 years overall survival rates than the patients with primary retroperitoneal sarcoma. With local recurrence, they have a 5 years overall survival rate of about 30%, and of the primary, they have about 66%. The resection of the recurrent sarcoma has a positive prognostic effect on the overall survival and arises it from 29% to almost 60% again. So it can get compared with the primary retroperitoneal sarcoma, only if resected. And is there really a big difference, or are they the same? The primary, is there no difference between a primary retroperitoneal sarcoma and a local recurrence? As you all know, surgery due to recurrence is also always a bit more difficult because you have the postoperative adhesions and you have somehow different anatomy. So this group, also from United States of America, they studied exactly this question, and they only found out that the transfusion was less, significantly less when performing the relapse, the surgery for the local relapse, and the weighted organ score when performing surgery for a local relapse is much less, so which means that you don't resect much difficult organs when resecting a local relapse than the primary, which is actually a very interesting finding. And comparing both the primary and the recurrent retroperitoneal sarcoma, only the grading had in both groups significant effects on the outcome. They also studied whether these findings are also found after the first local relapse. What about if they had another local relapse, a second one? And what about the patients who develop a third local relapse, which I personally find too much. One local relapse is totally enough for a patient. You shouldn't live to get a second or a third relapse. But here also the data shows that it's significantly influencing the outcome of the patient regarding the overall survival when resecting the local relapse, whether it's the first local relapse or the second. Starting with the third local relapse, they found no significant difference. between resection and not resecting the tumor. But how about the quality of resection? Does that affect the overall survival when performing surgery for the first local relapse, the second, or the third? And in all three groups, it was highly significant that the complete surgical resection of the mass affects the overall survival. So it's very, very important that when resecting a sarcoma, as well as many other cancer types, of course, you must resect it as a whole, not an R2 resection. So we can summarize everything that the prognostic factors for retroperitoneal sarcomas are the patient-associated factors that are the age and comorbidities, his general condition, the tumor biology or the grading, the size of the tumor, and the histologic subtypes. The only prognostic factor that the surgeon can influence is the quality of the resection, which means the complete resection of the tumor, not just a part of the tumor. And the only curative step and most important factor is, again, the complete resection. The extended multivisceral compartmental resection is justified and is still the gold standard for retroperitoneal sarcoma. All the newer data, as I've shown you, emphasize this gold standard. And even in local recurrence, the complete resection is the most important step in the treatment of these patients. So thank you, and I hope for your questions and a discussion.
Okay, thank you for this informative talk. We will start by taking questions. If you have a question, please raise your hand. I have a question myself. You mentioned in the beginning of the talk regional hyperthermia for treatment of sarcomas. Like, what form of regional hyperthermia do you mean? Like HIPEC or isolated limb perfusion?
No, neither nor. We perform the regional hyperthermia is MRI guided. The patient are in sedation for it because it's very inconvenient for the patient. And the locality of the mass is being put on a temperature for 41 to 42 degrees. And we implant thermal temperature probes before the therapy within this localization, for example, in the retroperitoneum, to make the hyperthermia more accurate. And then, as the same effect with HIPEC, for example, the chemotherapy has much better effect on the tissue where it's having the hyperthermia. And it's a special.
So you do it before the operation in the radiation department in the radio.
That's a chemotherapy that we have. There are only 6 centers in Germany that perform this regional hyperthermia, actually, and the rest ones send their patients to one of these 6 patients. We have the luxury to have one at our hospital.
So it's image guided chemo?
It's image guided, yes, MRI guided.
And you give it intravenous or local?
Exactly, totally normal chemotherapy intravenously. And only the mass and the locality of the mass, for example, the retroperitoneum, are getting a hyperthermia, which is MRI guided.
So IV chemotherapy with local heat, MRI guided local heat.
Exactly.
Okay.
And we have very, very well results performing that as a neoadjuvant therapy.
And they do it in the MRI during the MRI, while in the MRI machine, or where?
Exactly. And that's why the patients get a sedation, because it's very inconvenient for a patient to lie so long.
How long does it last?
It's different, between 20 to 40 minutes.
Okay, I'll read about it. Okay, thank you. Do we have any other questions from the audience? Please, if you have a question, raise your hand. Any questions? We had 25 first participants. Surely someone has a question.
Maybe I have a question at you and at the audience, if I may.
Yes, sure.
Do you discuss the patients or oncological cases in interdisciplinary tumor boards in Egypt?
Yes, we do, but maybe selected cases, as I understood from a previous talk, that in some places, all cases go through an MDT.
Exactly. For example, to certify your center here in Germany as a certified center for sarcomas, for example, you have to prove that at least 95% of your patients are discussed pre and post treatment interdisciplinary in such a board. Otherwise, you don't get your certification, for example.
I think here straightforward cases do not go through this, but only cases where there is like where it's challenging to make a decision. These are the cases that are referred to MDT. We have a question from Dr. Islam. Yes, please go ahead.
Thank you, doctor, for this nice presentation. Sorry, I didn't hear the lecture from the start, but I'm an assistant professor in Oncology Center, Mansoura University, and we usually are confronted with difficult cases of retroperitoneal sarcomas. But from the conclusion you mentioned, I think you declare that there is no sufficient role of adjuvant chemo, radio, whatever target in retroperitoneal sarcoma, and you state that surgery is the main line of treatment. Is it a dictum? Yani we cannot think about any adjuvant treatment. We can go for surgery for the primary and for recurrent cases, or surgery, then surgery, then surgery, and never to think of any adjuvant or any supplementary tool with surgery, except for, as you mentioned, the hyperthermia. Okay, is that what I think is right?
Thank you very much for that important question. I concentrated in this presentation on the surgery actually and why we performed that radical resection. But of course, we perform or we do neoadjuvant and adjuvant therapies, whether chemotherapy with or without hyperthermia, and whether radiotherapy. And that's why we need to take the biopsy prior to any type of treatment, because you only have an indication for a neoadjuvant therapy, for example, whether chemotherapy, if you have a tumor that has a histological differentiation of worse than G1, for example, G2 and G3. If you have a G1 sarcoma, there's no indication for a neoadjuvant or an adjuvant chemotherapy. And we do it in Germany here like this. If you gave a neoadjuvant therapy, then you do also an adjuvant therapy after the surgery. We perform only adjuvant radiotherapy. For example, if you have a case with a G1 sarcoma, and you couldn't resect the mass with a white margin, with a white safety margin. So we have, for example, at one side, it's a marginal resection. In these cases, we put titan clips there where the resection is not that wide enough, and we perform an adjuvant radiotherapy. So we do these clipping of these structures to make it easier for the radiotherapist afterwards when he does his planning CT to see, that's the most area I need to concentrate my radiotherapy on. But we usually, of course, we do chemotherapy as a neoadjuvant and an adjuvant therapy. The problem with sarcomas is, as you also, of course, know, the most important chemotherapies are doxorubicin and ifosfamide. These two medicaments are known since the 70s, actually, and until now, no other drug showed better effect on sarcomas. Doxorubicin and ifosfamide have big side effects, especially on the heart. So many elder patients and patients with heart disease, for example, insufficiency, you cannot give them doxorubicin, for example. So then you would try to take the second line, trabectedin. If it's not possible, then you have docetaxel and gemcitabine. But starting from trabectedin, the results of trabectedin are not that good like doxorubicin, but they have an effect in about 50% of the patient, not more. So you really need to think about it, whether this sick patient, cardially sick patient, should risk this chemotherapy or not. And all the results of all studies that have been performed till now show that there's a big difference between a sarcoma that has been resected and a sarcoma that has not been resected, whether you give radiotherapy, whether you give a chemotherapy or not. The patient always profits from resecting the tumor. Yes.
Okay, thank you. Do you have any other questions from the audience? Dr. Walid?
Yes, hello. I would like to thank you for your talk. I have a question myself. If you have a retroperitoneal huge sarcoma and the biopsy shows that it's a spindle cell tumor for excision, would you wait for the marker study before resection, or you would go for resection?
No, I would just look at the grading, to be honest with you. And I would hope it has a grading of 2 or 3. So we would perform a neoadjuvant treatment.
Okay.
With the hope of downsizing the tumor. And if it's a G1, then you have nothing else to do but performing a surgery. Waiting for the markers doesn't change anything.
Okay, thanks a lot.
You're welcome.
Dr. Gamal Amira?
Thank you for the presentation. I have some questions. First question is, in retroperitoneal liposarcoma encircling the kidney, when I have the radiologic findings that the kidney is free, do I have to resect the kidney within the fat of the retroperitoneal mass, or I can remove the fat and I strip the kidney and I leave it? Because sometimes when we remove it, we find the kidney in the pathology completely free. This is the first question. And second question about recurrent cases that have recurrence on the duodenum. Do you consider operable, or I go for Whipple operation? And last question, cases infiltrating the inferior vena cava. Do you make graft after removing of the vena cava, or you depend on the collaterals that usually are present within a long-standing retroperitoneal mass?
Thank you for the questions. For your first question, whether sparing the kidney or whether resected, we always resect it, even when we know that it's not that adjacent to the organ. Because maybe I can show you the slide where it was been analyzed. Here, about 1/4 of the patients, without assumption of these organs being invaded, have an organ invasion. So you think macroscopically that it's not invaded, but the pathologist says it is invaded. Of course, you can say in 3/4 of the patient, the organ was not invaded. So is it justified? If the mass was away, there's a big space between it and the kidney. And if the other kidney function, if the kidney function of the other sided kidney is not well enough, so if this patient would need a dialysis afterwards, in this case, I would consider leaving the kidney and sparing it exactly, but I would surely perform a post-operative and adjuvant radiotherapy. But if the other kidney was well functioning, I would resect the kidney en bloc with the whole retroperitoneal space. Regarding your second question, with the recurrence involving the duodenum, we always perform a Whipple procedure. That's always operable. If the third question, we don't see it commonly, but I saw it a few times, that patients with having mass, whether affecting the superior vena cava or the inferior vena cava, when they develop collaterals. So of course, you don't have to put a prosthesis, a graft afterwards, because it would just have more side effects. If the patient doesn't need his vena cava, then you don't have to make a new one, because he will need to have an anticoagulation for his life. And if you don't need it, then I wouldn't do the graft. But you must be sure that his collaterals are enough, of course.
Thank you. Thanks very much.
You're welcome.
Dr. Ahmed Morsi. You have a question from Dr. Ahmed Morsi. Please unmute. Yes.
Hello.
Yes, we can hear you.
Hello.
Yes, thank you for the interesting lecture. As far as I understand that, so long that by the PET-CT there is no evidence of distal metastasis and the tumor is localized, whether primary or recurrence, you will usually go for resection. What is the plane exactly you go through while you are stripping the fat from the muscle? And the second question, what is the limit when you say, if it is not metastatic, when you will say that, no, I cannot go for resection in this case?
For the first question, the boundaries, I always perform a compartmental resection for sarcomas. And we define the compartmental resection with, which is resecting of the whole compartment where the mass is lying, including its boundaries, which means the fascia. For example, you always have the fascial membrane on the muscles. We resect this too, as it's the anatomical boundaries of this compartment. So this way, we make sure that all the tumor cells are within the resection, within the specimen. For the second question, it's a very nice question. When does the patient come who we say there's no possible for resection? For example, if the vertebra are affected, are invaded, we resect them if it's not a big amount of them. We do it for, I did it twice for thoracic vertebra, but I didn't have any case with retroperitoneal sarcoma that affected the vertebra. We resected together with the neurosurgeons. We free the spinal cord and we make an internal fixateur for to fix the vertebral column. But of course, before performing this kind of surgery, this kind of real radical resection, it should be a young patient. It should be a patient where you think, okay, you will make him invalid somehow because he will not be able to rotate the vertebral column, for example. I wouldn't do it in a patient who's 80 years old or 70 years old, for example. It should be a young patient that can do the physiotherapy afterwards, that can, because he has months after surgery where he needs rehabilitation. Older patients, don't do such a long rehabilitation. They will end up lying in bed and then the surgery was for nothing. Maybe they have no tumor at all, but they have no quality of life if they only lie in bed for the rest of the days. So these are factors that you must consider. The same goes for the aorta, for example. I find the resection and implanting a graft for the inferior vena cava much easier than for the aorta. But for the aorta, it's also very possible. If you're infrarenal, there's actually no complications for it. Just the anastomosis must be good enough. With no stenosis, then they have no effects. They just take aspirin afterwards. So it's very few cases where you say, okay, that's very major surgery that cannot be done. And if it's a surgery type that I cannot do alone, for example, with bony structures and so on, I discuss it with the orthopedics, and we discuss it. That's why in the interdisciplinary tumor boards, because if such a major surgery had complications, you as the surgeon are the last one who wants the patient to say, he just performed surgery that was just not justified. So that's why we need this interdisciplinary conclusion that this surgery should be done. And of course, you need the structures in the hospital and the capabilities of doing such big surgery.
In cases infiltrating the psoas major muscle, and you have to go take the whole psoas with the lumbar plexus inside, is the morbidity following surgery is accepted for the patients, or how can they deal with it?
It's very accepted, actually, because they can perform these movements of flexing the lower limbs and with abdominal wall muscles. And what I usually do is I leave a very small amount of the muscle, and the patient will have the physiotherapy afterwards. And 1 year after surgery, you will notice almost no difference in the size of the muscle when it's strained. But if you needed to resect the whole of it, 100% of the iliopsoas muscle, the patients can move completely. They don't really notice the difference because they learn then, okay, they cannot stand up from bed exactly directly straight ahead. They need to perform it with a slight rotation of the vertebral column to use the abdominal wall muscles, the external oblique muscle, the internal oblique muscle, and they're usually enough, surprisingly. It's exactly like in the extremities, for example, when we resect the whole adductor longus compartment. I usually take one of the vastus muscles and transpose it into the medial size, for example, of the knee. Straight after surgery, the patient has just opened his eyes. I ask them always to adduct both legs. They can perform the movement excellently. You notice almost no difference, almost. And that's why you have to have a good physiotherapist that works with you, because almost all patients with sarcomas, almost all of them have a musculoskeletal resection, and they need the rehabilitation and the physiotherapy afterwards to become, to get the function as much as possible back to normal.
Thank you. Thank you very much.
You're welcome.
Dr. Gamal Amira again.
Thank you. I have another question, please. For compartmental resection for recurrent cases, I think it is very difficult to have a plane and a new compartment that is surrounded by fascia or surrounded by a parent plane. They are always difficult, and they are always near the cava or great vessels or pancreas. I think I very rarely found recurrence of retroperitoneal tumor that is accessible to compartmental surgery that can be done in the first operation.
That's right, 100%. But defining the compartment is then a little bit different, because the compartment is having boundaries around the mass. For example, if you spared in the primary surgery, for example, the left hemicolon, so it's your ventral boundary actually of the retroperitoneal. If it wasn't needed to be resected during the primary surgery, then it will be the boundary of the recurrence. If the recurrence, when you resect the whole fatty body of the retroperitoneum, of course, when a relapse occurs, it will be adjacent to any of the organs. These organs are then those boundaries. For example, if the pancreas is one of these organs, then you will have to resect the pancreas. And it's a multi-visceral resection. It's not a very typical anatomical compartmental resection, as you said, completely right. But as we have seen, the complications and is also very justified when resecting the slide, when resecting the recurrence. Usually, when performing a surgery on a relapse, it's more multivisceral, it's more visceral, intestinal or bowel surgery than anything else. But you can define your compartment by the organs surrounding the tumor.
Thank you. Thanks.
Dr. Islam Sahabi.
Assalamu alaikum. Dear sir, I want your help and your experience in another silly disease affecting the retroperitoneum. I faced a few cases in the last few years, and I really want your help or your experience in such a disease, which is the retroperitoneal fibrosis. Do you face such cases, and what do you do in such cases?
They're horrible cases.
Yes,
they're very difficult ones, but if you have a mass and you need to resect it, then you should perform the surgery. The difficulty is always to find anatomical structures, how to get the approach to the retroperitoneum, and they are very difficult cases. I agree with you totally. What you can do is, after taking a biopsy and after defining the histology, some of the cases can be treated by radiotherapy instead of surgery, and have the same results almost as resecting the tumor compared with the radiotherapy. If you need to resect the whole retroperitoneum, it's not that easy, and with the retroperitoneal fibrosis, like Wagner's disease, for example, they can make much more postoperative complications, because during the surgery you don't have really anatomic boundaries or anything that differentiate the organs from each other or the structures. So you can have much more intraoperative complications. And they need my experience is that you need to have eaten very well at the breakfast at the day of this surgery, because the ones I performed were all above 9 hours, because you need to be very slow to not to dissect through any structure or organ that you don't want to, and to define where your resection margins are. So it takes much more time, of course.
What about other lines of treatment? Steroids, tamoxifen, other lines. Can you go for such lines, or you go for this sophisticated surgery? I don't know. We didn't perform such surgery ever before.
If you have a defined mass, then I would take a biopsy first. If it's malignant, then depending upon the grading and what histology the pathology shows, you can discuss whether as I said, the radiotherapy is a good option. In some cases, it's a very good option, but not in all of them. The treatment, the surgical treatment must be very well thought in these cases. You are 100% correct. And not all of them benefit from surgery. In some cases, if it's not malignant, then cortisone therapy, for example, could ease the situation. And you should perform, of course, I would only do CTs or MRIs as a control in short terms, which is about in 6 weeks then. Because if it's not good, if it hasn't been a good idea, then you can notice it early, not when everything is over.
Yes, thank you. Thank you, sir.
You're welcome.
Thank you. Thank you.
I think the final question, Dr. Walid.
Hello, can you hear me?
Yes, please go ahead.
Yes, I have one last question, please. If you have a retroperitoneal sarcoma with a long-standing IVC compression and you can see dilated veins on the anterior abdominal wall, how would you surgically approach such a patient? In this case, would you go for which type of surgery and which approach would you prefer to avoid a sudden hypotension during operation?
I would approach it as every other retroperitoneal sarcoma. To be honest with you, if there are collateral veins, I would take a look at the inferior vena cava where there is still left perfusion through it. If yes, then I would implant the graft, surely, and the collaterals will become smaller after surgery, of course. If it's totally occluded, then you can resect it without implanting a graft. The difficulty here is it depends on where the collaterals are developed. We all know that collaterals are very fragile veins. If they bleeded, it's always a mass. So you need to take time. You need to, I would do a CT angiography maybe with venous, how is it called? With the late, after giving an intravenous dye,
Venous phase.
the late venous phase, exactly, thank you. So you can see the collaterals better where they really are. If you don't plan to implant a graft, you need to save every collateral. Everyone, because you don't know how the pressure inside the collaterals is and which one you can occlude and which one not. But the easiest way would be to implant a graft so the patient has his normal, almost normal blood supply again, so these collaterals would not be that important for the patient. So if you did injure one of them and had to ligate it in the surgery, so it doesn't have a major effect on the patient later on. And preventing sudden hypotension is very important in surgery, especially when doing any anastomosis, especially for bowel anastomosis. You need to, I always start with the big vessels and put tourniquets around them just in case. I never ligate or clamp a vessel long if it's possible anyway, and we always have a plan B. For example, if we injure the inferior vena cava, then how to clamp and how to suture it again, or how to find the bypass for the time being until we correct it. And these are, of course, the cases where the intraoperative complications arise that will affect the postoperative outcome.
Okay, thank you.
You're welcome.
I see one last hand raised. So Dr. Mahmoud.
Okay, can you hear me?
Yes,
Yes.
please go ahead.
Thank you for this talk. I'd like to ask if an iatrogenic rupture during a major heroic surgery for retroperitoneal sarcoma, is there any recommendation to do?
You mean rupture of the tumor mass?
Yes, yes, rupture of the tumor mass during a heroic surgery.
If it happened, then it happened. I would, after resecting everything, and I would keep, of course, the compartmental resection going, trying to resect everything that is left that can be resected. Then we perform a lavage of the retroperitoneum. And this is the patient, we call it T4 sarcoma with intraoperative rupture. These patients always get an adjuvant chemotherapy and radiotherapy and hope to reduce the recurrence rate.
Yes, okay.
And you use lavage only with saline or?
Yes, yes.
Yes.
We tried even HIPEC in sarcomas, but all the data did not emphasize the effect. So it just causes more morbidities than benefit for the patients if you, but I don't know any studies that studied lavaging the retroperitoneum with chemotherapy, for example. And you don't always have chemotherapy ready to use it if something like that happened. And you surely have to have the consent of the patient prior to surgery that you would use chemotherapy if anything happened. And usually you don't do that. That's why we only lavage with saline as much as possible. And these patients always get then adjuvant radiotherapy and chemotherapy.
Okay,
at least radiotherapy.
Okay, thank you. Okay, thank you, Dr. Hany, for. I hope you enjoyed it as much as we did.
Oh, I enjoyed it very much. Thank you very much.
And maybe if we have time in the future, we can arrange another talk.
Very gladly.
And we, of course, appreciate it seems that you had to translate your talk from German to English. So that must have been.
Yes, actually I did.
A lot of
I hope you understood everything.
Yes, that was fine. Okay, thank you, Dr. Hany, and looking forward to having you again with us. And have a good night, everyone.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Good night. Bye-bye.